I'll give the floor if anybody has any questions.
I just had a question.
Please.
The 31-year-old laborer that had that diffuse, what was his long-term outcome?
Knock on wood, he's still disease-free as far as we know, and he's back to work. I think he's 5 or 6 years probably for the hip replacement, something like that. So.
I have
Sure.
for diffuse, but I have a small localized in the back, and I'm actually going Friday to speak to the surgeons at Vanderbilt, and they're talking about doing arthroscopic surgery.
Yeah.
Would you recommend one or the other? I know the arthroscopic will be much easier to recover from.
Yeah. So it's just localized in the back of your knee right now?
Yes.
Just in one spot, sort of in the back. Of your
And
knee?
the front has been operated on
Okay.
already.
So that really comes to the expertise of the surgeons there. And if they have somebody who can arthroscopically access the knee posteriorly and be confident they can get it out sort of in one big piece, that's going to be a much easier recovery than an open synovectomy in the back. So sort of treating it like localized disease, even though it sounds like you had diffuse in the front. I think I would think an arthroscopic approach would be very reasonable, as long as I think they can get it out in one piece.
It kind of scared me because I was thinking maybe it should be open to make sure we remove it all. But it's still a good chance.
The MRIs are pretty sensitive to show extensive disease, and they will see the whole joints when they get in there. So I'll tell you, it would. I don't know if risk is the right word, but there's a chance they see more than they expect when they're in there. But if it looks like the MRI is reassuring and things, I would go for the arthroscopic for sure. Yeah.
Thank you. How do you guys feel more, Dr. Scharschmidt, about additives like cryo addition or ablation, any form of ablation? So we commonly get people want to pick almost whether you, for those, ablation is the use either of nitrogen typically, which is really cold, burns everything, or something really hot essentially, so it torches it. One is really destructive because it torches it versus the other, which is a little less. So it's kind of a meeting of the minds to figure out how destructive should you be.
Yeah, the local ablative therapies for TGCT, there we go again, aren't very well defined. And the problem with all of them is they're still ablative therapies and you're still working into joints. So for the most part, like sometimes with desmoid tumors or other diseases, we'll think about cryoablation or some of these other local ablations. But for this disease, if you're ablating something in the joint, you're probably ablating some of the cartilage in the joint as well. And that's going to cause the same damage that the TGCT is causing. So I don't think we know enough about it yet. I think there's a lot of things on the horizon with not only cryoablation, but embolization and different injections and things like that. We just don't know enough about them yet. So I don't know if Pittsburgh has any experience with.
We don't do a lot of the locally ablative for similar reasons. Not that I've seen. Yeah.
Let me ask one more. So it's correct that with the tumor in the back being localized, that instead of taking a drug trial, the first option for the tumor in the back would be to try to remove it. Is that correct? The best.
That would be my bias as a surgeon. I don't know.
I think it's reasonable. I think it's really tough, and you know, because is there a right or a wrong is probably not true. I think you have to take what we have, what research is out there, and then sort of have the discussion. I think that's really important among the multidisciplinary team, but also with the patient, and see what your preference is. You know, it's because there is a lot going into a drug trial and potential side effects and things. So I think each case has to be individualized as well. But I think it makes sense if it is localized.
Yeah, I just want to say too that none of the interventions that we have available will render 100%, cure, right? And that's a challenge. Everything is kind of like in a gray zone. So sometimes, one's wonder if maybe there can be an overlapping, right? Surgery and medicine or medicine surgery. We still don't have answers, and hopefully future research will help us shed light on that question. But I think Dr. Burgess is mentioning having a good conversation about pros and cons and see kind of what makes more sense to you and your unique situation. But life will be much easier if anything, will be 100% off, like medication, 100% cure, done. And you're like, okay,
Yes.
no more surgery, 100%. So, unfortunately, life is more complicated. But yeah, I think, good conversation probably will be great.
And the other, even before you decide treatment is, do the symptoms even require treatment at this point in time? Right.
Yes.
Okay, so we see some patients who
She
have
has
a
her
little
emotional
recurrence and,
Yes.
they're not really symptomatic with it. So sometimes we'll take a watch and wait approach, but if not, then, all of the trials that these guys talked about, the key inclusion criteria was not amenable to surgery for the most part, right?
Right.
So again, at least in today's world, surgery is still the gold standard for treatment for something that's resectable.
Mike.
So really you kind of talked about the asymptomatic, at least, so how do you really keep an eye on things when you're asymptomatic, but then things are still potentially destroying the joint? I mean, if it wasn't for another incident, she wouldn't even know she had PVNS or GCT, and her hip was about to break. So what are some things you do to try to keep an eye on that?
So I guess from my standpoint, because we do see some patients that come in occasionally that is discovered almost incidentally, right? Which is sort of weird and scary at the same time. But we see it that they injured themselves, didn't have any pain before the injury or whatever happened. You get an X-ray, it shows something funny. You get an MRI and biopsy, and it shows PPNS. So I think for the patients that we identify that are either asymptomatic or minimally symptomatic, and by minimally symptomatic, I would say, yes, you may have some swelling of your joint, but seeing everything we just showed you about the recurrence rate and the surgery and the medications, you're okay with dealing with a swollen joint, understanding it may lead to arthritis at some point down the road, then typically my practice has been to see you about every 6 months or so with a repeat MRI scan, just to have some idea about rate of growth, change in the joint, those sorts of issues. But I don't think there's a right or wrong answer to how to monitor for that.
And am I correct in thinking that you guys would agree that, if you want to make that decision, okay, now is the time to have surgery or start a treatment, you want to try to do it at a time where it's not too bulk, right? So you have more options available.
Yeah.
So by doing visits every 6 months and MRI scans, just to kind of keep an eye on things, then maybe you can start your intervention a little bit sooner before things get too out of control, perhaps.
Yeah.
So, go ahead. Please do. Yes. Okay. So same patient. So she's been on imatinib for 2 years. How long would you say it's safe to stay on imatinib? She's pain-free, so that's a blessing. But, we still want to make sure that it's not growing or changing or affecting her long-term. And she's 20, so.
No, that's a great question. I think with imatinib, that we probably, out of all of the drugs, we probably have the most data long-term looking at it, just because it's been around for over 20 years and used to treat other diseases. So, we can sort of extrapolate from some other diseases as well, that I'm not aware of any long-term effects from staying on it for, forever and ever and ever. But that's what we know, as of right now, but we do have all of that long-term follow-up. So I get it. I think that's the big thing is when, if things are going really well, do you stop it? Or, of course you run the risk of, could it progress again? And there's so many unknowns. It's a good question.
Yeah, no, I agree with Dr. Burgess. I think, initially Gleevec was approved for CML 1994. So we have data from all that time period. Of course, one of the questions is fertility, right? And especially if you're young, have young crowds. It's also, there is some data there. Of course, we don't have, we have to be careful with that, and everything has to be planned. But I would say that probably this is one of our drugs in our arsenal that we have the most data. And in terms of safety, I think, 1994. So, and the other thing I want to say is that, every time I can, I try to get away with the lower dose I can use, right? If I have the data. And that's also important for side effects and so on. But yeah, I think Gleevec is probably one of the drugs that we have best track record available.
So I also have a quick question. So only 40% of patients have follow-up. Do you have any recommendations as well on how patients continue, particularly surgery, that they can breach that conversation? A lot of surgeons will whip it out and say, "You're done, goodbye." So how to have that conversation for follow-up? MRI is really hard to get if your doctor isn't the amazing Dr.
To
Scharschmidt.
clarify what you're saying, are you saying that you have a statistic that 60% of
Yes,
patients have
yes.
surgery and then they never see a doctor again?
Bernthal et al. found that, yeah, only 40% have follow-up after
Wow.
surgery.
Yeah.
Especially if they're just sports medicine.
Oh, yes,
Yeah.
yes.
They're not like a.
Oncology
they're usually
specialized.
done with you.
Yes.
You have 12
Well, we're
weeks.
sarcoma doctors and I see people for at least 10 years for that. So no, that's a really, sorry. I'm just.
Yeah, it's one of my favorite, right? It
Interesting.
sends it home that we're just
Yeah.
forgotten in some regard in those cases.
Yeah, no, I think it's one of the challenges we have. And, and frankly, we have that discussion with patients now is some patients will come back and say, well, if it does start to come back, I'll probably have swelling again, right? And the answer is, well, probably. And then they decide just not to come back for any follow-up because they'll say, I'll call you if I notice a difference. So I think there's sort of a counterpoint on that side of it as well. But I mean, I think just this education piece is so important, and just, this crowd knowing that despite an operation, you may have a 40 or 50% recurrence rate. If you take that to your physician and say, hey, I know you did the best surgery you've ever done on my knee, but the reality is there's still a chance of coming back, and I would appreciate having an MRI every 6 months. I can't think of a colleague that would sort of say no to that, honestly. So.
I have a question about the systemic application of a CSF1 inhibitor, and what if there's any documented impact on your entire immune system?
Well, I think from the side effect profile, we haven't seen too much of like what I would see like a low white blood cell count or anything like that. Imatinib does have a risk of doing that. But I don't think it's too much. It's not like a conventional chemotherapy, right? Where you're losing your neutrophils and that kind of thing. But I'm sure there is some impact, but it's not, I wouldn't say you're not in like the highest risk category, like a stem cell transplantation or something like that.
Yeah, I completely agree. I think there is a spectrum of, how potentially crippling for immune system or chemotherapies are. And then we still, don't have all the detailed data on that, but I agree with Dr. Burgess. Usually these treatments do not, lower your counts in a significant way compared with other chemotherapies. Yeah.
Go ahead, Erica.
Okay, I had a question about recurrence post joint replacement. You said that the symptoms wouldn't be the same, obviously, because you're not going to feel the pain. What would those symptoms look like if there's a recurrence?
It's usually swelling. It's usually increased swelling. Some patients do get pain with it, but not as severe as you did with the TGCT. So it's usually swelling.
Would that include like limited range of motion again then?
It can, yeah. It's sort of the mechanical symptoms, the catching and locking, or losing range of motion is a big clue. If you had a knee replacement and you were 0 to 120 and all of a sudden you can only go 0 to 90 or 80, that would be sort of a clue. So all of those things essentially, but pain isn't one of them. So
right. Okay. Thank you.
So my question is more about post-surgical concerns, and what other hip issues do you find yourself having patients run into, like labrum issues, revisions, reconstructions, things like that?
You're speaking like after a synovectomy of the hip?
Because that happened to me.
Yeah. Yeah. So it depends a little bit so if you're doing a synovectomy on the hip without a joint replacement, that can look like a whole bunch of different things. A lot of times it'll be what we call a surgical hip dislocation, where the whole hip is popped out of the socket, so you can get a complete synovectomy around it. And just doing that procedure can put you at increased risk for arthritis, labral injuries, pain and stiffness in the joint, just from having the joint dislocated, essentially. So the hip's a hard one because it's such a constrained joint. It's not like the knee, the ball is really deep in the socket on the hip joint. So to get a complete synovectomy causes a lot of collateral damage to that joint.
Yeah.
So.
So for the medical oncologists, for systemic therapies, I look at trials and the first thing you see is it's generally well tolerated, which is a word that we use in science that patients never actually feel. So I'm curious, those generally well tolerated side effects, which one do you find the most impactful?
Yeah, we love to say that, don't we?
Love it, even safe and well tolerated, despite, itching your skin to death, but it's generally well tolerated.
Which of the side effects do you find?
Yeah, out of all the drugs, I'm not specifying, I guess, the drug, which one do you see in your patients you find most impactful?
I mean, I think that the liver problems cause a lot of issues. And it's not in all patients, obviously, it's approximately 30%, but
just have changes though. Only a small portion have significant changes.
Exactly. But a lot of stopping and starting. Like someone asked the question, like, how do you know what to do? It's like, well, you're checking the labs every week. It's important to hold, to dose reduce, and so that's really tough. I mean, I think also this is somebody, you're living your life, you're doing your thing, and you have this issue, and it's like, oh, by the way, now you're 25 years old, now your hair is going to turn white. I think that's significant. Is it life-threatening? No, but people share these things. I mean, I don't know. I feel like probably this question is probably best answered by you guys.
I'm just curious what you've seen the most as people bring it up.
These are things that I've heard.
Yeah.
Rashes maybe. But yeah,
Tinoco is like, yeah, rash.
Yeah. Rashes, and I think that can be really impactful that I've heard from patients, and swelling too.
I was just curious what you guys' opinion of the spectrum of the side effects.
Yeah.
Yeah, I would say, I mean, I think there's the degree of severity, right? Like in what we do, we can like to classify things, right? And go for grade 1 to, grade 5, of course. So usually what we see more often with these drugs is grade 1, grade 2. That usually doesn't require you be in the hospital for whatever side effects you're having. But it depends on the patient. There are two more that I think I've seen most disruptive with these drugs is basically edema, like facial edema mainly, like periorbital edema, and skin rashes. I think those are kind of like sometimes disruptive. Sometimes people don't want anybody else to know that something is happening with them. And this is kind of.
And that seems to be part of the actual class of drugs, right? All of the drugs have some form of that. Yeah.
Exactly. So it is kind of what I was seeing more.
And yeah.
As far as recovery for I don't need that.
I'm only recording, sorry.
I'm already loud.
As far as recovery after surgery, I see a lot of questions, how long should I do physical therapy? How long is it going to take for me to be 100%? But you never really hear like the doctors say, well, really it's for life, right?
Yeah.
And I want to know, you as a surgeon, do you ever recommend like blood flow restriction therapy? Because I think that's a big miss for people like us.
Yeah, so there's all kinds of things I would sort of put in this bucket of non-conventional things that we don't think of enough, right? Whether that's the blood flow restriction things, whether it's like dry needling or acupuncture, sometimes things like turmeric or these different, anti-inflammatory medications. And so number one is I think it's important to have those discussions going into the operation, which unfortunately doesn't always happen. But number two, my thought has always been for any of those things in those buckets, as long as you're not on something systemic that's going to sort of interact with it. I say that a lot of those are just trial and error. They may help a lot of people. We've had a tremendous success with dried needling sometimes for some joint stiffness and things like that conventionally we shouldn't be sort of recommending for people, right? So it's oftentimes trial and error, and I think it's important to get these different modalities sort of out there so other people can give them a shot and try. So.
And as a medical team, has there been any research to get with physical therapists, like the board of physical therapy, to recommend special care for people with our disease? Because I know I've seen a lot of physical therapists, and I keep recommending, look into our disease because we require certain things that your average patient would not.
Yeah, not that I'm aware of as far as formal recommendations, but
the closest would be the consensus paper, which does recommend PT unspecified because so many countries and healthcare systems are involved, but there is a recommendation for PT, but the duration has to be the art of medicine, kind of depending on the healthcare system and the doctor itself, but.
I'm glad you brought that up though, because if no one asked about it, I was gonna ask you what your take was on physical therapy, because as a medical oncologist, like, there are some patients who have never had surgery. So I guess I'll just bring this up too, because I know that this is like maybe an elephant in the room of like, somebody comes in with pain and swelling and they have an MRI that's very consistent, what do they say? Like, looks like a duck, walks like a duck, it is a duck, that kind of thing. And so do you really need a biopsy? Some of these patients never have surgery so I'll end up starting to talk to them. And I mean, I consult with the whole team. But should that early referral for physical therapy, even while you're taking systemic therapy, I think is probably good to get that range of motion and yeah, so I think it's like educating, involving the physical therapist in the team, and at more specialized centers that hopefully there'll be more discussion about that.
And insurance
yeah.
also, right? Some insurances only cover 100 visits versus 12 weeks of surgery. So that plays the biggest
And
role.
you get a copay every time you go to physical therapy, right?
I know physical therapy helped me before surgery.
Okay.
It, ramped up my muscles when I had to be down.
For sure.
And a lot of doctors don't recommend that either, which I think is a loss for, especially if it's knee or hip, it's important to build up all your glutes and your quads and everything when you're dealing with the knee and keep them stretched. Because when they're tight, it's gonna be painful too.
To try and get them more involved, we do, just for you guys as well to know that we do work with some people who go to the support groups know that a physical therapist comes every 3 months and just goes through when you should have physical therapy. You don't need surgery to have physical therapy and those things. So hopefully with collective collaboration, we can all involve them more as well. I'm gonna take this over then. For just curiosity, what do you guys as providers think is the greatest issue in education on your side of other doctors, right? Like all of us have, I'd say probably majority of us have met a doctor that thought that they could remove it. They shouldn't have touched us and they should have referred us, right? So how do we bridge that? What do you think is the solution from your side?
I think we get this question a lot.
That's why I'm putting the onus on you guys.
Probably the insurance carriers, I would say. Because, getting to see orthopedic oncologist is a big factor in our disease, and a lot of insurance companies don't want to refer you that far because they don't realize
Without a tissue
what you have
diagnosis.
going on.
Well, yeah, you have to have a diagnosis first, yeah.
Yeah, I mean, I think it's just the education, honestly, more than anything. And we struggle with all these sort of rare diseases we take care of, unfortunately, not just TGCT, but the more people that know about it, the more patients that advocate for themselves. I think that's sort of the key, honestly. We talk about it every national meeting we have about, when to refer and when not to refer, and it still doesn't happen. So I don't know, it's an ongoing challenge for sure.
I mean, you talked about the challenge of the diagnosis, and that was another issue we had with our daughter, and that, kind of the first MRI was, this looks like TGC, but then she had almost 2 other biopsies that basically were, there's this goo, we don't know what it is. I mean, so and it only wasn't until the 3rd procedure that they went into the joint, and then they said, well, okay, we got enough that it was confirmed. So and just from what I read online in the group, it does seem that the whole biopsy sometimes can be a challenge. And is that?
Yeah. I mean, 100%, and we've talked about this in terms of some of the clinical trials and things, needing a tissue diagnosis for enrollment on the clinical trial. If you've got some of those examples I showed, that very sort of frondy, diffuse disease, it's hard for the radiologist to go in there with a needle and sort of pin a piece of that down to get us an accurate sample. So then you're looking into like an arthroscopic or an open biopsy, which is onerous, but probably the right answer.
After the 3rd procedure to finally do it.
Yeah, that's not uncommon. I mean, I don't know if that's reassuring or not, but we know that there's a delay into establishing this diagnosis.
Sorry,
No, I can't say enough about this organization. I mean, like the other rare diseases that we treat, because I think you really are making an impact, because how else, it's a hard question, because you know, everybody has medical training in different places, and you don't know what you don't know, and it's really tough. But I think if you're a patient and you're being an advocate for yourself or a family member, it's really helpful. And I think that unfortunately you're gonna run into situations where people just are not open to having conversations. And I know that that's really tough, but I think it's your right to go get a second opinion. You know, it happens.
Yeah.
And I mean, it happens, you know, all the time. So, but that is really tough.
I mean, we battle it within our own Orthopedic Oncology Association in MSTS. You know, and some of the early PEXI data was presented at our national meeting. There were some of my colleagues who stood up and said, well, you know, there was 1 or 2 deaths on the phase 1 trial that was a much higher dose and different indication. Like, I'm never going to give a drug that even has a 0.1 risk of death to a patient for a benign disease. So a lot of even my colleagues in orthopedic oncology are resistant sometimes to considering systemic therapies or different options. So, you know, multiply that or extrapolate that out to, you know, a community orthopedist who maybe has seen PVNS one time in their career. It's an uphill battle for sure.
Mhm.
Yeah, I think we all collectively share in that value.
Yeah.
Does anyone else have any questions? Yes, Woody.
I don't have a question, Cindy.
Yeah.
But it seems like one of the shareholders that's not necessarily represented here is the insurance company.
That's Sydney's side.
My insurance wouldn't let me.
Wow.
I take out-of-pocket payments. We battle that even with these, we talk about surveillance scans of following people with at-risk disease for recurrence, or maybe they haven't had surgery or following. I don't know how many peer-to-peer calls we've had of trying to get that MRI approved because GCT isn't on their checkbox of what we approve the MRI scan for if you don't have active disease or you're not doing anything for it. So usually after an hour on hold, you can get through and get it approved, but it's an onerous process for sure.
And for example, for PET CT scan, it's the same problem, right? Like when you have like a new,
That's even
like,
worse, yeah.
and then they say no, and then it's just really frustrating. And believe me, we spend hours every week just trying to fight these fights, and it's just so draining, and it shouldn't be like that.
That's a greater healthcare issue that
And-
we won't be able to tackle, but collectively can complain.
And these are issues that we bring up with the pharmaceutical companies too, designing clinical trials, because sometimes if they can provide extra funding to get that PET scan approved, and we're going to collect more data, so we're going to know, and then down the line, hopefully we can get drugs approved. The insurance companies hopefully will recognize. I don't know. I'm just kind of hoping that, but if we can get funding to get them on trials, I think that's important.
Go ahead, Woody.
Yeah, so all my doctors, I'm the only person with this condition they've ever seen. So this is the first opportunity I've got to talk to anybody that's not new to it. So I was curious, we're at a point after 3 surgeries that I'm getting ready for a knee replacement. And every time I've had a surgery, I wake up and it's like worst case scenario is my condition. So before, you know, we do the knee replacement, I'd like to ask you, worst case scenario, like what's the shortest amount of time that I can expect to get some benefit before I can expect another surgery? If everything went wrong, I mean, it's from, I think a lot of y'all can relate to it. Like it's as bad as it's going to be, we're going to get it.
I mean, with 100% full disclosure, I've had several patients go on to amputation for PVNS. I've had several patients go, worst case scenario, I've had several patients go on to amputation for TCGT of the knee. It has failed multiple surgeries, multiple synovectomies, multiple lines of therapy, and they're just done dealing with it. And that is drastic, but we were talking about this earlier, but some of the advances we have in amputee care, that gives you your most reliable surgical operation to sort of get on with your life. So
I will say that's also elective, right? There's very few
Elective.
instances where it's
Correct.
medically required.
yeah,
Yes.
it wouldn't happen during your knee replacement.
Yeah.
Like, yeah, but so your question, so for a standard knee replacement for arthritis, I usually tell patients it'll be around 3 months until you're convinced it was the right operation to do. I would say for PVNS involvement with that, probably double that amount of time. So I think it's going to probably take you, somewhere between 3 and 6 months to see a meaningful benefit from the operation. It's a little bit longer recovery.
Thank you, Woody. And Woody's also on trial. So we have the whole gambit here. So thank you, everybody, unless there's, okay, as long as there's no other questions, we will start lunch, but please give a very loud and very.
I unfortunately can't stay for lunch. I have to run back over to the Children's Hospital, but Sydney can share my email with the group. I'm happy to sort of connect with anybody offline or discuss things or anything I can answer outside of today's meeting. Feel free to reach out to me anytime.
And please grab food.
I will
Feed the
definitely
children
do
if you have to.
that. I will feed them. I'm not going to surgery, but I can't feed the children.
Don't feed the children.
Don't feed the children. Right. Awesome.
So there is food out there. Make some form of orderly line would be perfect.
Oh, yeah.